So now let's come to the Andromeda trial. So how do a combination of CRT, pulse pressure, diastolic arterial pressure, and basic echo together help classify hypovolemia, vasoplasia, and cardiac dysfunction? So what made you bring all these three into one category and help us in classifying hypovolemia versus vasoplasia versus cardiac dysfunction?
Yeah, so the first, let's say, branching of the tree on our protocol is done by pulse pressure. And pulse pressure is a nice surrogate of stroke volume. It's cheap, it's simple, and it's bedside. And pulse pressure is determined by aortic compliance and stroke volume. So with a low pulse pressure, you're probably having a low stroke volume, and then we test fluid responsiveness. So then we can assess if the patient is actually preload dependent or not, and give fluids accordingly. So if we find a patient with a low pulse pressure and fluid responder, she's probably requiring fluids and hypovolemic. On the other hand, if a patient has a normal pulse pressure but a low diastolic blood pressure, diastolic blood pressure will be determined mainly according to vascular tone and heart rate. And there's a nice paper by Professor Ospina that he mixes these two and called diastolic shock index. And these patients are broadly vasoplegic. So in this sense, what we're aiming here in this, let's say, other subset is to increase vascular tone through vasoactive drugs and avoid giving fluids if they are not required. And if any of these two big interventions fail to identify or to restore capillary refill time, we come to the beginning of tier 2. That's a basic cardiac echo to rule out right or left ventricular dysfunction. So with these three interventions, we can check these big, let's say, patterns or phenotypes that we were talking about.
So it's amazing. You covered all the things. You looked whether the patient is hypovolemic, or maybe the vasoplasia is playing a role, or maybe the cardiac dysfunction, and accordingly you precisely decide about the therapy of the patient. So very well planned. But how reliably can these macro phenotypes be identified without advanced monitoring? Is there any role?
What we have is we published last year or this year preliminary data, and we found that pulse pressure at least has a very nice specificity over 90 to identify a low PTI with a cardiac echo. So we cross-checked pulse pressure and stroke volume through echo, and we found that it has a big specificity. And also the diastolic blood pressure signal, there's a study by Antonio Gustavo Spina Tascon that assessed this relevance, and also another one by Professor Tebul that he used an acronym called VNERI to assess vascular tone and responsiveness to norepinephrine. So at this sense, I think that even though they're not perfect tools for a first approach, and we must remember that usually we do not have access to echo at the beginning of resuscitation, and we do not have access to, let's say, cardiac output monitoring at the beginning or during early resuscitation. So these simple bedside tools can help us sort out, at least in this protocol, 63% of the situations and normalize capillary refill time without using an echo was required only 1 out of 3 patients. So this is the nice thing of the study.
So when you talk of the diastolic arterial pressure, it's quite a bit of under-recognized thing, I believe, because classically we have been taught to look after the MAP. All guidelines, be it the sepsis guideline by SICM or the sepsis group, they all talk about the MAP. But here very well we have spoken about the diastolic arterial pressure. So is it something which is under-recognized resuscitation target in vasopedia? And what is the interpretation of the success rate of DAP augmentation of more than 50 millimeter of mercury?
Yeah, that's also, I think, DAP is the forgotten brother of the mean arterial pressure, or the forgotten sister of the mean arterial pressure. And actually, it's a signal that we're looking at vasoplegia, and probably increasing vascular tone could enhance not only arterial flow, but also coronary perfusion. And in this sense, in the study, 120 patients went to the DAP test or to the DAP augmentation, and only 20% in normalized capillary refill time. So it was a little bit, we found it a little bit insufficient compared to the other tests. But when you see the raw numbers, when you see the absolute decrease, capillary refill time decreased a lot from 7 to 4. The problem was that it did not reach the threshold of 3 that we categorize normal to abnormal. So right now we're running some post hoc analysis to see the true value of these tests, and I hope we can have them soon finished. But we're still is under construction.
Yeah, amazing. Would be interesting to have a look at that data as well. Thank you very much, Dr. Eduardo, for doing this, and you're very much welcome to our channel that is called as CritiTalk.
So thank you all for being here. My name is Eduardo Catán from Pontificia Universidad Católica de Chile, and today we will discuss in this next 20-25 minutes about the Andromeda-SHOCK 2 trial. And as you all know, septic shock is a lethal disease. More than 11 people a year die from sepsis. And the most severe, let's say, stages of sepsis called septic shock. And within septic shock, we have let's say, a myriad of circulatory dysfunction in which we have hypovolemia, vasoplegia, cardiac dysfunction. But on the other side, we have these microcirculatory derangements that include heterogeneity, microthrombosis, decreased microvascular blood flow, that at the end together end up determining tissue hypoperfusion, decreasing tissue oxygenation, organ failure, and finally death. And in this sense, we have like a two-phased Janus in which we have a macrocirculatory derangement, but also microcirculatory problems, and resuscitation strategies to try to improve or restate tissue perfusion have moved, let's say, between these two lines. So in the 90s, we had this big clinical trial by Michel Hayes, which tried to test the hypothesis of focusing solely on the macrocirculatory part, and they increased cardiac index to supranormal levels. And even though they reached cardiac indexes of 4.5 or 5, unfortunately, patients randomized to the treatment group had a lower survival rate as seen in these Kaplan-Meier curves. Then back to the 2000s, it's a Rivers, with the River protocol, the early goal-directed therapy, brought into the spotlight central venous oxygen saturation, let's say a marker of oxygen consumption and delivery adequacy. And even though the protocol was retested afterwards by the ARISE, PROMISE, and PROCESS trials, let's say this brought the attention not only to the macro, but also to oxygenation and oxygen balance. And in 2010, Tim Janssen and Jan Bakker published the early lactate guided therapy that now the hierarchical variable was, let's say, lactate decrease or lactate normalization. And the macrocirculatory interventions, let's say fluids, vasopressors, inotropes, et cetera, focused on normalizing or decreasing lactate. So at this moment, this was taken by the Surviving Sepsis campaign, and lactate was, let's say, the holy grail of the marker of tissue perfusion. Yet, when assessed the recovery dynamics, lactate was not as, let's say, consistent as a marker, because in some patients, lactate decreased slowly, or there were other sources of lactate that were not related to hypoxic or hypoperfusion, say liver dysfunction, adrenergic, excessive adrenergic stimulation, etc., etc. And back in the 60s, 70s, already Professor Max Harry Weil, one of the fathers of shock, had studied the skin as one of the bedside monitors to assess adequacy of perfusion and flow. And in this trial, he showed that the difference in temperature between the great toe and central temperature was a better indicator of the severity of shock than central or macro hemodynamics. And in 2014, we did this study in which we followed 100 septic shock patients that survived, actually, and 100 survivors. And we did a multimodal assessment of tissue perfusion parameters, including lactate, microcirculatory derangements, and skin perfusion, such as capillary refill time. And what we can see in the study was there are two major landmarks. The first one, that at 2 hours, almost 70% of patients had normalized capillary refill time, and that lactate was still abnormal at 24 hours. And this was the basis for the Andromeda-SHOCK 1 trial that compared a resuscitation strategy targeting capillary refill time versus targeting lactate, serum lactate levels. And this was done in 424 patients in 5 countries from Latin America. And it followed a strict, let's say, protocol: fluids first, then vasopressors, and then imodilators. And even though in the frequentist assessment, the study had a borderline p-value 0.06. In this post-hoc Bayesian analysis showed that probably targeting capillary refill time was beneficial in more than 90% of the scenarios according to the priors. This was taken by the Surviving Sepsis campaign. They recommended using cap refill time as one adjunct of tissue perfusion monitoring. But we still followed with this, let's say, stepwise approach: fluids first, vasoconstrictor second, and finally inotropes. And how could we move forward and try to improve the results of our resuscitation practice, trying bridging in all the new information we already had from these years? And this is where personalization and trying to phenotype came with a big punch into the literature, and we see all these, let's say, opinion leaders focusing or trying to shift away from a one size fits all approach to a personalized resuscitation strategy. And this is what we were trying to bring into this concept, that as patients in septic shock are not only vasoplegic, they have, let's say, different components of hypovolemia, ventricular dysfunction, and vasoplegia. And this was nicely demonstrated by Guillaume Guéry and Antoine Villard-Varon in France, in which they did transesophageal echo to assess cardiovascular clusters through machine learning. And they found that 20% of patients had a left ventricular failure as a predominant syndrome, 20% a right ventricular failure, 20% were still hypovolemic, and 20% were hyperkinetic. So that's where, let's say, our recent randomized trials, this was one of the questions that probably randomized to liberal versus restrictive fluids or high versus low MAP targets, are not addressing adequately the heterogeneity of our patients. And should we just try this approach, or can we go a little bit deeper? And if I would like to recommend one review, one review is this one by Daniel Debacker and collaborators, in which they perform a plea for personalizing the hemodynamic management of septic shock. So this is how ANDROMEDA-SHOCK 2 was born. The study that now I'm going to present that started the inception in 2021, and we completed it early this year and was presented on the ESICM conference and published simultaneously in JAMA. And the key question that we tried to answer was, does a personalized hemodynamic resuscitation strategy targeting capillary refill time normalization improve outcomes in early septic shock compared to usual care? So now we're not only targeting capillary refill time, but we are also using a personalized hemodynamic resuscitation strategy. And what we did, we did a randomized clinical trial in 86 centers in 19 countries in patients with early septic shock, those within the first 4 hours of septic shock, between March 2022 to April 2025. And the trial was overseen by an independent data safety monitoring board that performed 2 interim analyses at 200 patients and at 75% of the sample size. Our objective was to compare the effect of this personalized hemodynamic resuscitation, targeting capillary refill time normalization, on a hierarchical composite outcome of mortality, duration of vital support, and length of stay versus usual care. And our hypothesis was that this protocol would improve this composite outcome of mortality, vital support, and hospital length of stay. So patients that complied with the inclusion criteria, let's say septic shock defined as sepsis 3 in less than 4 hours since diagnosis, were randomized in a 1-to-1 ratio, stratified by center, with allocation concealment to avoid identification of the randomization sequence, through a web-based system that we use, the Castor electronic data capture. And patients were randomized either to CRT-PHR, that's the acronym of the intervention, or to usual care. We had some exclusion criteria, including patients that had been diagnosed over 4 hours, patients with active bleeding, DNR, patients with cirrhosis or life expectancy under 90 days, a pregnant woman, and ARDS patients and patients in which CRT could not be accurately assessed. And our primary outcome was a hierarchical composite outcome that included mortality as the first tier, then duration of vital support that included time from randomization until the last of these was stopped, either vasoactive, mechanical ventilation, and renal replacement therapy, and length of hospital stay at 28 days. And we calculated a win ratio. That's basically what we tried to do was to compare all patients in the control group to all patients on the intervention group and check if they were on the first outcome, let's say mortality. If the first outcome was a win for one, it was counted as a win or a win to the other. But if there was a tie, let's say both patients survived, then we checked the second outcome that was duration of vital support. And if there was a tie at that stratum, then it was checked for length of hospital stay. So it gives a higher relevance to mortality rather than the less relevant outcomes like length of hospital stay. And we also used some secondary outcomes, including basically the same mortality, vital support free days, and length of hospital stay. Some key aspects of the methods: we standardized the assessment of capillary refill time using this glass probe, which was compressing the index finger for 10 seconds until the finger became blanched, and then counted with a chronometer the time it took to recolorate until the previous coloration. And we consider an abnormal capillary refill time if the time it took was over 3 seconds. And during the 6-hour study period, this was our intervention protocol that had 2 tiers, tier 1 or tier 2. And I will show you some of the fundamental pillars of this protocol. So the first pillar was the capillary refill time was a hierarchical resuscitation target. So if capillary refill time was normal, no further interventions were done, and we just checked patients 1 hour after each other to see if everything was okay. So let's say if patients had a normal CRT, nothing was done, just monitoring. The second one was trying to identify these individual hemodynamic patterns, and we tried to do this using bedside simple tools such as pulse pressure and diastolic blood pressure. Because under the assumption that pulse pressure is a surrogate of stroke volume and diastolic blood pressure of vascular tone. So if pulse pressure was the surrogate of stroke volume and diastolic blood pressure as a surrogate of vasodilation. So and finally, the third, let's say, aspect to get the pattern is bedside echo in the tier 2 to identify left or right cardiac dysfunction. And finally, whenever we had a signal that patient should be tested for fluid responsiveness, before every fluid challenge, we perform a fluid responsiveness test, either with pulse pressure variation, stroke volume variation, or passive leg raising, etc., according to the clinical context. And the fourth pillar, and this one that's more interesting, at least for me, is that we did some acute hemodynamic tests that were reversible for only 1 hour. So we did a mean arterial pressure test. We increased transiently MAP to patients that were chronically hypertensive and assessed if capillary refill time normalized or not. And the same, we give a low dose of dobutamine in patients that everything had not improved, trying to open the microcirculation. And if at 1 hour either of those tests responded or not, they were continued or stopped accordingly. Also, just want to show you that we had a very tight control of adherence, and we did a lot of training. And at the 6 hour, there was a dedicated team that were looking at the interventions to see if the study participants adhered or not to the protocol. And then we did the follow-up up to 90 days. On the statistical aspect, we had a target sample size of 1,500 patients. And with that, we had a power calculation that provided us 88% power and with an alpha level of 0.05. And as I mentioned we used the primary outcome, the analysis as a win ratio, and it can be expressed as the proportion of comparisons between intervention and controls in which intervention won over control. Now to the results. We recruited 1,501 patients from 86 ICUs, 19 countries, and 4 continents, including North America, South America, Europe, and Asia. This was recruited for almost 3 years and 2 months, and we had a ratio of patients screened to randomized of 1 to 3. This is our consort flow chart. 4,500 patients were assessed, and 1,501 were randomized, and finally, 720 were included in the primary outcome analysis for the intervention group, and 747 to the control group. These patients were at the baseline, they were quite severe, had SOFAs of 8, Apache scores of 19, and had high comorbidity index with a median age of 66 years and some of the comorbidities. And regarding septic shock characteristics, most of the septic shocks were abdominal, and they were randomized basically 2 hours after diagnosis to the intervention. The patients had received at least 1,500 mLs before study inclusion and had a baseline lactate of 3.7 and a baseline capillary refill time of 4.0. And regarding the primary outcome, patients, the control group, the intervention group had a higher rate of wins through this win ratio analysis with an effect estimate of 1.16 and with a 95% confidence interval of 1.02 to 1.33. And this gave a p-value of 0.04, making the study significant for the primary outcome. When we see which components of the win ratio provided more wins to the intervention, it was primarily driven by the duration of organ support. And this is, let's say, this is confirmed by the secondary outcomes in which patients were randomized to the intervention had, in average, 1 more day of vital support, 3 days. When assessing subgroup analysis, the patients with higher SOFA, higher lactate, or higher capillary time seem to have increased benefit from the intervention with higher win ratios. And as stated in the paper, patients that were randomized to the intervention group had lower capillary refill times at 6 hours. And we see how not only the numerical value is different, but the number of patients with a CRT under 3 was around 87% in the intervention group versus around 60% in the control group. I would also like to show you some results on the trajectories. You can see that 36% of the patients entered the protocol with a normal capillary refill time. So these patients, actually, we did not do much on resuscitation. And 65% of them normalized capillary refill time with tier 1, let's say the simple interventions. And at the end of the day, 86% fulfilled the protocol with a normal capillary refill time. And regarding interventions used, patients in the intervention group had a lower use of resuscitation fluids, had lower net fluid balance, increased use of the butamine, and a little bit more of use of norepinephrine at 6 hours. They also had less CVP and lower lactate levels that were significantly different as well. Just to show you what's also very important to me, that when you stratify patients according to if they had normal or abnormal capillary refill time at inclusion, we see that in the intervention group, the interventions were actually tailored to those with abnormal capillary refill time. And you see how fluid responsiveness assessment or the butamine, et cetera, were specified to those with abnormal capillary refill time, highlighting the importance of personalization. And the adherence was quite good. We only had 6% of deviations in the protocol. And of course, this study has a lot of limitations, as any big randomized trial, included that it was not unblinded. Decisions of vital support were made by local practices. Capillary refill time and fluid responsiveness testing might be subject to inter-rater variability, and also the protocol might be seen as a labor-intensive or impractical protocol, etc., etc. But in conclusion, at the end, we concluded that among patients with early septic shock, a personalized hemodynamic resuscitation protocol targeting capillary refill time was superior to usual care for the primary composite outcome, primarily driven by a lower duration of vital support. So before we finish, I'd like to thank all our sponsors, all our universities that helped us with resources. We did not have funding, but we had a lot of nice people behind our study that put a lot of effort, a lot of heart into it. And of course, a thanks to all our patients and all their families for believing in us and agreeing to participate in this study. Thank you very much.